Hi everyone, good afternoon. My name is Olivia Hensey from the New England QIN-QIO, and I will be your moderator for today's webinar, Pay for Performance Program, What's Changing and Why You Should Care. The Quality Innovation Network Quality Improvement Organization, QIN-QIO, works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at a specific time in the presentation. I'll provide you instructions on how you can pose a question in the chat box. Due to time limitations, we will not be taking questions over the phone. At this time, I'd like to introduce today's speakers, experts from the New England QIN-QIO. They include Brenda Jenkins, Michele Kelvey-Albert, Lauren Capizzo, John DeStefano, as well as Dr. Chris Campanile, a practice physician partnering with the New England QIN-QIO. So before I pass this over to Brenda, I'd like to give a little bit more information on our Med Minutes podcast. The webinar today is addressing the first three podcasts we have created, revolving around quality reporting. The New England QIN-QIO is pleased to offer you support, education, and information for optimizing your systems to increase rates of preventative services and prepare for value-based payment. Our Med Minutes podcast address these topics and more. Each podcast is approximately 10 to 15 minutes long and available for you to access from our website at your convenience. I will now pass the presentation over to Brenda. Thank you.
Thank you, Olivia, and welcome, everyone. We're going to start out with just a short introduction to the Pay for Performance program. As you may be aware, the U.S. healthcare system is the most costly in the world. It accounts for nearly 17% of our gross domestic product, and there are estimates that that percentage will grow to nearly 20% by 2020. Increased longevity and chronic health conditions have contributed additional pressure on the healthcare system. IHI developed an approach to these compounding issues through the well-known AAA, which promotes a three-pronged approach. They look at improving the patient experience of care, which looks at both quality and satisfaction, improving the health of population, and reducing the per capita cost per healthcare. CMS and many private payers are moving from a fee-for-service model to a pay-for-performance model. National quality reporting programs, which began with incentives to encourage participation of providers, has now incorporated penalties for not reporting satisfactorily or performing and having a low performance rate. As a family physician and consultant here at the New England QIN-QIO, Chris, can you share with us your perspective on how these payment models impact the physicians?
Yes, Brenda, thank you, and thank you for letting me provide perspective from a practicing physician. And while I think most of us physicians, advanced practitioners, support the overall movement of reimbursement for medical care from one based on volume to one related to value or quality of care, there's also a general negative sentiment toward many of CMS's pay-for-performance programs. To document and code properly, providers must now spend an inordinate amount of time outside of direct patient care. This has led to feelings of anger, frustration, burnout, and a loss of control over their own profession. In addition, given that the scoring for CMS's P4P programs is generally on a relative basis, it automatically describes about 25% of providers as delivering poor quality care, which many resent. While I feel that I and other physicians and advanced practitioners are delivering safer and higher quality care, I don't think we've figured out how to do it without having a significantly negative impact on the professional lives of this country's clinicians. And this is after much progress in the areas of team care and electronic health record support.
Thank you, Chris, for sharing that very important yet sobering perspective on what the feelings are down in the trenches. One of our goals here at the QIN-QIO is to provide some clarity on these programs and how to navigate them. We also can provide coaching on timelines technical assistance, and workflow redesign to help support practices to become successful through navigating these quality improvement and reporting programs. Now, next slide, please. Before we open the webinar up to questions, we're going to provide a very high-level summary of the quality reporting programs that we highlighted in our previous podcast. But first, we did want to show you a snapshot of the future of quality reporting incentive programs. The Medicare Access and Reenactment Act of 2015 proposes a streamlined approach by taking three programs, the PQRS program, the Value-Based Payment Modifier, and the EHR Incentive Program, or Meaningful Use, and rolling them into a merit-based incentive payment system. Now, the proposed rule will be coming out this summer. You will have an opportunity to share your thoughts. CMS will be opening up to public comments beginning in March, and then I believe closing those in June. And next slide, please. Now I'm going to talk about the Physician Quality Reporting System, or PQRS. The program began in 2007 as a way of introducing quality reporting to physicians providing services to Medicare beneficiaries. Over the years, it has evolved from a process-based measurement program to an outcomes-based reporting program. It has also become aligned with other quality reporting programs such as Meaningful Use, and it is the foundation for the Value-Based Payment Modification Program. It is applied to all eligible providers. Now that includes all physicians, practitioners, and therapists who bill Medicare Part B physician fee schedule. You can report either as an individual or as a group if you're in a practice of two or more. Reporting requires 9 PQRS measures across 3 of the 6 national quality domains. Those are the same domains that are used in Meaningful Use, or you can report on one group measure set, which may have any number of measures involved in it. 2014 was the last year to receive incentive payments through PQRS, and in 2015, if you are not successfully reporting, you will receive a 2% negative payment adjustment, which will be applied in 2017. There are a number of different methods of reporting. It's important to note, however, that claims reporting is only available if you are submitting data as an individual. And the other methods of reporting, such as the qualified registry, through your certified EHR, through a QCDR, or through the GPRO web interface, can be used depending upon the size of your practice and the measures that you are reporting. And now I'm going to just share with you what the deadlines are. There has been a new memo that was released. The deadlines for reporting through all of those measures except claims has now been extended to March 11th, 2016 for 2015 reporting year. For claims, it remains as February 26th, 2016. And now I'm going to turn it over to Capizzo to talk about the value-based payment modifier.
Thank you, Brenda. So I'm going to tell you a little bit of the summary information from our recent podcast on the value modifier. The value modifier provides for differential payment to a physician or group of physicians under their Medicare Part B physician fee schedule. And that's based upon the quality of care furnished along with the cost of care furnished during a particular performance period. As this table depicts, the value modifier is being phased in over a 3-year period. It began with larger practices in 2015, and it impacts all physicians in 2017. It's important to note that it's applied based on a 2-year look back of your PQRS reporting, and it's relative to the size of your group practice. So while the value modifier is applied only to eligible professionals, or EPs, that are physicians, it's actually the total number of EPs in your group, which would include nurse practitioners, PAs, or therapists, and physicians, which determine the size of your practice. So for the calendar year of 2015, it was applied to physicians in groups of 100 or more EPs, and that was based on their 2013 PQRS reporting. For this calendar year, 2016, the value modifier will be applied to physicians in groups of 10 or more EPs, and that's based on the 2014 PQRS reporting. Finally, in the calendar year 2017, the value modifier will be applied to all physicians based on their 2015 PQRS reporting. Another thing that's important to note about the value modifier is while PQRS data is used to calculate the value modifier, it's not the only data that CMS uses to calculate the score. CMS uses two scores which contribute to the calculation of the value modifier: the quality of care composite score and the cost composite score. The composite scores are calculated using a combination of PQRS reporting and claims data, and each score is worth 50% towards the calculation of that value modifier. So the value modifier will continue to impact Medicare physician fee schedule payments, and that's going to occur from 2016, 2017, all the way through 2018. In 2019, PQRS, the value modifier, and meaningful use will all be incorporated into MACRA. Now I'm going to turn it over to Michele Kelvey-Albert. She's going to give an introduction and an overview of the podcast for the Chronic Care Management Code.
Thank you, Lauren. So the Chronic Care Management Code, so CMS recognized that care management is a critical component of primary care and contributes to better health and care for individuals, as well as reducing spending. So in 2015, they began reimbursing physicians for the care they provide for a particular group of Medicare patients remotely, so non-face-to-face visits. And the new code for CCM is 99490. Many physicians have just started to be using this code. CMS requires that this remote care meet a few criteria, like patients must have 2 or more chronic conditions, the physicians must establish a comprehensive care plan. So some of the things in those care plans will be treatment goals, self-management goals, medication lists, and that remote care must take up at least 20 minutes of staff time over the course of a month. Medicare patients must consent to the service once every 12 months, and they are subject to an $8 copay over 30 days if the CCM code is billed. And so many of the physicians that are starting to use this need to get assigned consent from their patients before they start billing this. But again, it gives them an opportunity to bill for services that primary care physicians do every day. Calling specialists, following up with the specialists, things that are done behind the scenes that have not historically been able, that physicians have been able to bill for.
Fantastic. Thank you, Michele. The next slide is the CMS Help Desk Resources section. As you can see, there are some phone numbers and emails that are available for you to use at your convenience. As I'll say at the end of this webinar, these slides will be available through our website so you can access them later. If the presenters have anything else that they would like to add on this slide, please go ahead. If not, I can forward on to the next slide. Okay, fantastic. So thank you, everyone, and at this time we'll take some questions. If you would like to ask a question, please pose your question in the chat box. I just sent in a chat to everyone that has said the same thing, and we'll take as many questions as we can. However, please be assured if your question is not addressed during this webinar, we will make sure someone gets back to you to address your specific question. So we'll give it, a couple seconds here for people to ask some questions. We have some further, questions that we'd like to address here through our presenters, which we can do, but we'll give you guys a couple minutes to see if there's any questions that you would like to pose in the chat box. Thank you. Okay, so while we're waiting, we have a couple questions from Michele. Do you want me to ask the question, Michele, or would you like to ask the question? You can answer it on your own.
Sure. Many of the times when I'm working with primary care physicians, there's been a lot of questions about can you bill the Medicare transitions code and the CCM code in the same month? And the answer to that is no. You cannot bill these in the same month. However, the care transitions code, if you bill that, let's say you're billing that in February, you're not going to bill the CCM code, but then in March, you can continue to bill the CCM code for your patient. So can't do it both in the same month, but you can continue to do that after the other month. The other question that comes up is, does a provider need to provide 24/7 patient access to bill for CCM services? The answer to that is yes, that the practice must offer 24/7 access to care management services, a platform for direct patient-practitioner communication, and the ability to manage transitions between providers and settings. So what we're talking about is if you are a practice that has an EHR that you can access remotely and you're able to get into your patient's chart and access their care plan, that qualifies. It does not mean that every specialist that you work with has to have direct access into your EHR, but you have to be able to say to your patients if they were to get in touch with you that you have access to their care plan 24/7. So those are two questions that come up a lot. I'm going to send that back over to Olivia, which we have some other questions through the chat.
So one of the questions we have that I think Brenda or Lauren can answer is, where can we see how CMS scores our PQRS, given that it is 50% of GDM? What scores do they expect the provider to reach? Is it by specialty?
So thank you for that question. I think there's a combination of things that we look at. It's not just straightforward the PQRS measures. They look on a national level, aggregate the data, and take a look at where the median is for those measures. They also have another calculation so that they're making sure they're comparing apples to apples. For example, when they looked at the cost measures for providing health care in New York City is not going to be the same as the healthcare costs in Oklahoma. So there's a number of different calculations that are performed on the CMS side of things, and where you can find those results are in your QRUR reports and your physician feedback reports that are available even at the individual provider level on an annual basis. I hope that answers that question.
And so I'm just going to add to that and say that the QRUR report stands for Quality and Resource Use Reports, and in order to access those, the providers would have to create an Enterprise Identity Management System account, an EIDM account. And formerly that, prior to July of this past year, it was an IAX account. But those reports are available for all providers and can submit for PQRS. You can see that detail within those reports, and you can find that on the CMS website. I believe we have a link out on that for those resources.
Fantastic, thank you. Brenda or Lauren, do you have any other questions that you would like to pose or talk about on your end?
We have a question that came up and comes up frequently, and it's this is Lauren. It's about the definition of a group and understanding, is it true that CMS requires that a group be comprised of at least 2 or more Medicare physicians in order to meet the definition of a group practice? And so this is with regards to PQRS as well as the value modifier. And no, that's not true. CMS defines a group practice as a single PIN or tax ID number with 2 or more individual EPs, those eligible professionals, and they would be identified as EPs by their individual NPI number, and they've reassigned their billing rights under a particular PIN. So an example that we've used is if a primary care physician and a nurse practitioner are practicing together under one kin, they would actually be considered a group, so it's really just two individuals. Only the PCP, to note, would be subject to the value modifier impact, but the nurse practitioner would be included in that total EP count. So that would be for 2015.
Fantastic. Thank you, Lauren. We had another question on here that asks you to explain how this information impacts skilled nursing facilities, and I think Michele can give a brief answer to that and might be able to follow up if that answer is not sufficient.
Thank you, Olivia. For the CCM code only applies to primary care, so it would not apply to the skilled nursing. I don't know if Lauren or Brenda, if you have anything that you would add from the value-based modifier on skilled nursing, and if not, we certainly can get back to the person that asked that question with more detail.
Thank you, Michele. This is Brenda. So the only thing that I would add to that in terms of skilled nursing facilities, the PQRS measures are based specifically on Medicare Part B physician fee schedule. So anyone within that SNF that is submitting those types of claims would be subject to PQRS reporting and to the value modifier.
It's very important to consider the method of billing when you're thinking about these programs.
Hi, everyone. This is Michele. Just one note, just to follow up with that, too. We did get a comment about accessing the QRUR reports. And so providers are encouraged to reach out, as mentioned, Brenda mentioned this in the slide, for the QIN-QIO staff for assistance in downloading and interpreting their QRUR reports. So we just wanted to reiterate that support.
Wonderful. Looks like we don't have any more questions in the chat box.
Michele?
Yes.
Oh, hi, Dr. Campanile. I just wanted to clarify something under the CCM code that it sounds like Medicare had relaxed the so-called Incident 2 regulations relating, say, for a nurse to a primary care physician. And it's just a nurse, say, could be working and the physician might be out of the building that afternoon, but she is still able to make contact with the patient and bill under that 99049.
That clarification, Dr. Campanile.
Wonderful. Is there any other clarifications or updates or questions that the presenters want to pose at the current moment? It looks like we don't have any left in the chat box. Wonderful. So,
Olivia, this is Brenda. I just wanted to make sure that everyone on the call was aware with the implementation that's expected of NACRA and NIST that we will be doing a webinar on that proposed rule and educating people about what they need to know. And we hope to do that in the next couple of months.
Wonderful. And Brenda, it looks like we have one more question here directed towards you. Brenda, I'm an individual clinical social worker, and I work closely with some PCPs I care for their chronic patients. Can I be reimbursed for those consultations with the PCPs?
That sounds like a CCM question.
Okay.
So this is Michele. So physicians and non-physician practitioners may bill for the CCM code. Where they define in the CMS literature as certified nurse midwives, clinical nurse specialists, nurse practitioners, and physician assistants. Now, the clinical social worker can work under the PCP in order to bill for that, but they would not be able to, under my understanding of the code, bill directly unless you are those eligible practitioners that I just named.
Thank you, Michele. again, thank you all for a great discussion, and I have a few last-minute announcements before we end today's call. Again, if you have a question and it has not been addressed, please reach out to the experts that are on this panel here. We will have their information for you in the presentation you can access, and please don't be shy to reach out to them with questions. Remember that you can access and download our Med Minutes podcast as well as our other podcast series on immunizations called Give It a Shot on our website. Visit www.healthcarefornewengland.org and click the purple Med Minutes audio podcast button or the green Give It a Shot button. This will take you to the Med Minutes page where you can easily download any of our podcasts. Also, please stay tuned for our second series of podcasts beginning in March, which will focus on care transition. Thank you all for a great discussion again. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. And if you don't have time to fill out the evaluation right now, or you're currently sharing the computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation, as well as the link to the event page on our website where the presentation is. I've also included that link in the chat box. The PowerPoint presentation is already posted, as I just said, and within the next few business days, a recording and a transcript will also be added. Thank you all for attending, and I hope you all have a great day. Thank you very much.